This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Derek Stitt from Mayo Clinic. On today's Neurology podcast, I'm joined by University of California, Irvine's Ali Habib, neuromuscular specialist and one of the authors of the recent article, Hospitalizations and Mortality from Myasthenia Gravis, Trends from 2 U.S. National Datasets, which will be publishing January 23rd in the Green Journal. This study examined trends in hospital admissions and readmission for adults with myasthenia, as well as both in-hospital and post-discharge mortality. Ali, we really appreciate you sitting down with us on the podcast today.
Thank you for having me.
So before we get into the details, as we all know, every study, no matter how big or small, starts with a hypothesis or a question that it tries to answer. And so I was just wondering, what was the nidus for your group to do this study? Was there something that you were all appreciating anecdotally or a change in the landscape that you had noticed?
We've always talked about how we've been doing a good job in terms of curbing mortality from myasthenia gravis exacerbations and myasthenic crisis. And some recent literature that had been published by groups outside of the US had pointed to higher mortality in other regions. And that kind of prompted us to take a second look at what was going on in the US compared to what had been published previously several years ago.
Set the stage for us and tell us about the sources for your data gathering and the scope of your data set.
So we were looking primarily at the national inpatient sample, and there had been 2 other studies published specifically on myasthenic crisis from the 2000 to 2010 time range. And so there had been quite a bit of a gap from the last time that this was looked at. And so we kind of recapitulated that methodology looking at the national inpatient sample. In addition to that, what we looked at was the Medicare limited data set, which is a separate group of information covering the United States.
How big of a data set are we talking here as far as raw numbers of patients?
In terms of the national inpatient sample, that covers data from really across the US, and it's a stratified sample that's taken from there, covering the entire US, about 20% stratified sample. And the total numbers that we were looking at were a 10-year time frame was about 56,000 admissions for the national inpatient sample. In contrast, the Medicare limited data set is a smaller data set and specifically covers patients who have Medicare or Medicaid. And within that, we were limiting it to the older age groups. So for that data set, we were looking at about 2,000 admissions during the 2010 to 2019 timeframe.
Wow, that's an impressively large-scale study. I'm hoping you can remind us again the characteristics and outcome parameters you looked at for these myasthenia admissions.
Just to lay the ground for how the data appears in these data sets. So in the national inpatient sample and in the limited data set, we were looking at patients with a primary physician diagnosis for myasthenia as the reason for admission to the hospital. And what that means is that is the first diagnosis listed on the list of diagnoses for any individual hospitalization. For the national inpatient sample, this really is aggregated data, whereas the strength of the limited data set is that it is de-identified individual level data that covers these admissions.
Tell us about specifically some of the parameters that you were looking at, like admission rate, right? You looked at readmission rate, mortality, any other key points that you were looking at to compare across those 10 years?
Right. So what we did was look at myasthenia gravis in that primary position and then looked at what the length of stay for patients during those hospitalizations was, their outcomes in terms of mortality, what kind of treatments they might have received. And specifically, this was focusing on the need for respiratory support to help us dichotomize the data into patients who were admitted with MG exacerbation, but not necessarily MG crisis, and those that were admitted for myasthenia gravis crisis, which specifically is defined as needing ventilatory support. We were also looking at readmission rates for patients that were admitted with myasthenia exacerbation or myasthenic crisis.
And then you also looked at those same parameters based on age group, correct?
That's correct. We also were looking at the differences in these rates based on different age groups, going from 18 years to the oldest old in these data sets.
Okay, so shifting now to your findings. So over this 10-year period that you looked at, what did we see regarding admission rates nationwide?
What we observed in both data sets was that there was an increase amongst all age groups in admissions for both myasthenia gravis exacerbation as well as myasthenia gravis crisis. What was interesting was that the older age groups were having a greater increase in the rates of admissions over the period of observation compared to younger age groups. On the good side of things, the mortality rate remained stable throughout the time frame that we were looking at, though the trend that we noted was that the mortality rates were higher amongst the older age groups compared to the younger age groups. The length of stay also was fairly stable, though what was interesting here is that it's not something that we think about very much, but there was a considerable readmission rate, about 20%, and this rate remained stable throughout the observation period.
With that increase in admission rates, do you think that's likely solely based on just our increasing elderly population, or do you think there's more to it than that?
As you know, there is not a lot of detail about comorbidities that we looked at and what other factors might have influenced this. So it's a difficult question to answer based on the assessments we've done so far, but it's certainly something that needs further look in terms of figuring out what is responsible for this increased rate. Now, one thing that is there is that we know that the incidence of myasthenia is probably increasing in the older age groups. And how much of this increase in admissions rates has to do with that increase alone remains to be seen.
Yeah, I thought it was very interesting. Your paper brought up increasing awareness with regard to incidence increasing, even brought up things like the introduction onto the scene of checkpoint inhibitors and how that could have potentially be an influence at increasing these rates. Obviously, the main driver, but at least something that could be in the mix for sure. You mentioned that readmission rates remained stable. So looking at that, while admissions went up, readmissions stayed fairly level. What about in-hospital mortality and length of stay over that time period? Again, can you just remind us? Because I loop those together because one would presume that if your higher morbidity cases have longer length of stay, crisis versus exacerbation, like you had mentioned, and so therefore secondarily a higher risk of mortality. What were you seeing with that?
Exactly right. I think the patients who were admitted with a crisis had longer lengths of stay compared to those that did not have myasthenia crisis. The overall trend was stable in terms of length of stay for either category and for the different age groups. In terms of mortality, again, the overall mortality from the national inpatient sample fortunately remained quite low. It was about 1.8% for the total group. That said, the mortality rate amongst the older age groups was certainly higher at about 5%, looking at the Medicare limited data set.
So yeah, it really seems like age was a recurring theme on most of these parameters. So when I learned from this paper that admission rates, although they've significantly increased, mortality and readmission rates, like you said, are fairly level over this time period. So that makes me think that we seem to have done a good job, at least at a healthcare system level nationwide, of maintaining or keeping up with the status quo and managing myasthenic exacerbations and crisis on a system level fairly well, despite the increased numbers. But however, you pointed out that this data cuts off at 2019, with the exception of the Medicare data set, which went to 2020. So most of that was pre-pandemic, except for 1 year in one of the data sets. And so, first off, does that sound plausible that our system seems to have handled this increase from an inpatient side of things? But I wondered what your sort of gut feeling is about if COVID might have affected this. We just don't know.
I think I agree with you that we definitely, fortunately, have done a good job in keeping the mortality rate stable throughout this time period. And this is again predates the advent of the newest therapies that are available for the treatment of myasthenia. There is very limited information we got from this analysis regarding the impact of the COVID pandemic. But I think that's a very important question because we know so many of the factors that we discussed here have a bearing on outcomes related to COVID infection. And we are more concerned about patients with myasthenia, not only because of their susceptibility to respiratory failure, but also because of their immune compromised state from the treatments that they're on. So that's certainly a next good step to look at outcomes related to the COVID pandemic amongst this patient population.
Putting this all together, myasthenic exacerbation and crisis admissions, they seem to be continuing to rise, although we don't have post-pandemic data to look at. But it seems like at least prior to COVID, our system was keeping up well on a national level. My last question to you as an expert clinician and a researcher in myasthenia and who's published on some of these novel myasthenia therapies, do you have optimism that outpatient immunotherapy advances like these newer FC and complement inhibitors can positively influence the risk for exacerbation, and crisis across the board? Could that help slow down these increasing admission rates on a large scale?
We hope so. I think armamentarium in terms of what we can treat patients with myasthenia with has increased tremendously over the past 5 years, as you noted, with the advent of the complement inhibitor therapies and the FcRn inhibitor therapies. And more importantly, these therapies can be instituted fairly quickly and have an impact on curbing disease really rapidly. So the rapid onset of action certainly is helpful. And we would hope that with these therapies, along with the therapies that we already had, we would have the ability to prevent hospitalizations, exacerbations, and certainly crisis in patients who are at risk.
And maybe once we figure that out and that question gets answered, we'll have to have you back on the podcast. So, well, Ali, I really enjoyed reading your paper, and it certainly made me think about the landscape of myasthenia in the modern world. And I really appreciate you coming on and sharing your insight.
Thank you so much again.
All right. Well, that's all for today. Thanks for tuning in. I'm Derek Stitt for the Neurology Podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.